Okay, good afternoon, everyone. Welcome to the fifth session of the Hematology Grand Round, live from Tehran University of Medical Sciences. After the incredible success of our last Hematology Grand Round sessions on AML and ALR, we are back bigger, bolder, and ready to take a deep dive into the cutting-edge world of updated treatment of myeloproliferative neoplasm in 2025. This isn't just another academic discussion, it's a movement, a space where brilliant minds come together to challenge and to shape the future of hematologic research and treatment. So buckle up, engage, and let's make this session nothing short for groundbreaking. A special thanks to a praise to Race team for their invaluable support in organizing this event and to all of you for your commitment to advancing leukemia research and patient care. The session will begin with a keynote presentation by Dr. Naveen Pemaraju, followed by a moderated discussion and an interactive question and answer session. And we encourage you to actively participate by sharing your question in the chat box. Please join me in welcoming first Dr. Sohrab Aghabegi for insightful presentation and to introduce our distinguished keynote speaker. Dr. Sohrab Aghabegi is our recent Assistant Professor of Hematology and Oncology at Tehran University of Medical Sciences with extensive experience in leukemia treatment and clinical research. Dr. Aghabegi, please introduce our keynote speaker, Dr. Pamaraj.
Thanks a lot. Good morning, good afternoon, good evening. On behalf of Iran and North America, International Iran and North America Academic Partnership in collaboration with International Affairs Office of Shariati Hospital, I want to welcome you all to this fifth session of Hematology Grand Rounds. I am Dr. Sohrab Aghabegi, Assistant Professor of Hematology and Medical Oncology at Tehran University of Medical Sciences, Shariati Hospital. And today we are so honored and privileged to have one of the foremost experts in the field of leukemia, Professor Naveen Pemaraju. He works as a professor in the MD Anderson Cancer Center in Houston, Texas, in the MD Anderson. He's the director of Blastic Plasmacytoid Dendritic Cell Neoplasm program in the MD Anderson, and additionally, he serves as executive director for cancer medicine at the MD Anderson Cancer Center. Professor Pemaraju participated and led many of the practice-changing and cutting-edge studies all around the world, especially in the United States, and he serves as a PI on numerous key clinical trials on the field. And today we are really so glad to have him here. Today we want to talk about myeloproliferative neoplasm. As we all know, there are a lot of new studies, a lot of new data, a lot of new drugs are on the way. For example, in 2023, we've got momelotinib, a new JAK inhibitor. It has FDA approval, and a lot of new other drugs are on the way. And I think that in 2025, maybe it is time to reevaluate the way we think of managing myeloproliferative neoplasm and its complications. A lot of new drugs, anti-CD123. After TAG, we have a new one that is on the way. We have BET inhibitor, a lot of new drugs. And today we hope that we will have a great discussion with Professor Pemaraju. And thanks a lot for all of you. And I hope that you all participate in the talk and ask your question from Professor. And we will have a question part, and we will ask our questions from Professor. And I hope that we will have a great time. Professor Pemaraju, the floor is yours.
Wow, thank you so very much to my friends and colleagues, Dr. Marjan, Dr. Sohrab. I want to tell all of you, my friends here in Iran, what an honor and a privilege it is to be here with you and to do this collaboration. Dr. Marjan, your words inspired me with this call for action and international collaboration, so very timely and very important. And on behalf of my mentors here, Professor Hagop Kantarjan, Professor Guillermo Garcia Monero, and our friends, our mutual friends, Dr. Sanam Logavi, Dr. Amir Fati, Dr. Maziar Shadman, it is my great honor to spend this hour with you discussing one of my passions in my life, really, which is the rare blood cancers. And we'll focus today on the myeloproliferative neoplasms MPNs, and I have been recently named as the co-section head for the MPN section here at MD Anderson. So without further ado, I want to give some objectives to our colleagues, Iranian colleagues, for our discussion today. 4 objectives for today. Let's talk about focus just on the 3 classical ET, PV, MF. We used to skip over the ET and PV sections, but actually you'll see quite a few slides. There are some exciting developments. I also want to remind all of our experts here, all of us know the driver mutations, JAK2, CALR, MPL, but let's really make sure we understand how they're important in diagnosis, prognosis, and can you believe it now in phase 1 treatment. And then, of course, let's be able to talk about some of the new and exciting developments in the MPN field, which usually I think start in US and then eventually can be available worldwide. So my friends, we must start with history. It was William Damashek, who was the very first president of American Society of Hematology, ASH, in Boston, 1950s in America, who started seeing these patients in clinic and said, you know, these 4 types of patients have some common background. And there he was talking about essential thrombocytosis, polycythemia vera, myelofibrosis, and CML. Of course, CML, chronic myeloid leukemia, now separated because of Philadelphia positivity, and the 3 remaining originally called Philadelphia negative MPDs, myeloproliferative disorders. The phrase that sticks in my mind some 70, 80 years later is he felt that there was perhaps a hitherto undiscovered stimulus. How right he was. Well, so as we separate out CML, we really are focusing on ET, PV, MF. Worldwide incidence is very low. These are rare diseases when we compare to other blood cancers such as multiple myeloma. Perhaps only 2 to 3 out of 100,000 people, affecting male and female. Most of our talk here will be on older patients with MPN, but I wanted to highlight that my group, we have a special interest in the young patients with MPN, pediatric, adolescent, young adults, so younger than age of 40. And actually, the more that we think about a diagnosis, there's a lot of patients walking around, teenagers, 20, 30-year-olds with MPN. So don't forget, in the patient with high platelet count, maybe it's not reactive, maybe they may need a bone marrow biopsy, JAK2, CALR, MPL testing. So let's begin. So myeloproliferative neoplasms, as they're now called, cancer, not disorder. The natural history is quite bizarre for most of our blood cancers. Most of these PVET are thought to be indolent cancers, but unfortunately, because people forget about them, then they forget how lethal they can be. So in the early term, we're looking at vascular events, not just clotting, which is what we always talk about, but also bleeding and hemorrhagic. So either way. Now, in this phase, PV, ET, and even early low-risk MF, patient lives decades, maybe even a near normal life expectancy. However, as all of you know, either presenting de novo or transforming to, once you get to myelofibrosis, particularly intermediate to high risk, I want to emphasize this is no longer a chronic disease. It's actually an acute disease in many patients. Patients with myelofibrosis, as you all know, can be characterized by constitutional symptoms or B symptoms, fevers, night sweats, weight loss, a cachexia-type presentation, extramedullary hematopoiesis as the liver and spleen come back to help out a failing bone marrow, progressive cytopenias ultimately leading to infections, fatigue, and transfusions, and unfortunately, as you know, a high propensity to transform to AML, acute myeloid leukemia, which is absolutely one of the worst forms of AML to have, post-MPN AML, with a median overall survival, guys, of like 3 to 6 months. And so all of our treatments that we'll talk about today, can they modify the disease and can they halt the progression to AML leukemia and early death? Exactly 20 years ago now, exactly 20 years ago, 2005, was when the JAK2 V617F was elucidated, only 20 years ago. What does that mean? From that moment on, you went from MPD disorder to neoplasm to cancer. 4 or 5 independent groups elucidated this. And what's remarkable 20 years later, no matter if you're in Iran or Houston, it's always the JAK2 V617F. There are some small non-canonical variants, but this is the one that's somatic and recurring. I find that to be mind-boggling. Most cases not hereditary. Now, the JAK2 allele burden percentage may vary from ET to PV to myelofibrosis, as our group and others showed many couple of decades ago. But no doubt it's the same mutation that occurs. So in your systems, we want to be checking for the JAK2 V617F. Amazingly, in 2013, a second mutation, as you all know, was elucidated. This is breathtaking. I was sitting in the ASH late breaker session in New Orleans, And back then, this had not yet come out. Two back-to-back UK researchers showed CALR, C-A-L-R. It's a ER chaperone protein, calcium binding protein, that for some reason is very important in driving MPNs. Not PV. PV is JAK2, but ET and MF. And can you believe it? This became the second most common mutation overnight added to the diagnostic panels and really helps to diagnose patients, particularly with JAK2 negative ET. You don't know if it's reactive or clonal, so the CALR mutation. And then finally, don't forget about MPL. This is a good board question to remember. 5 to 7% of ET and MF, MPL mutation. And maybe just remember that this is the proto-oncogene that encodes for the TPO receptor, so thrombopoietin receptor. Importantly, all three of these, JAK, CALR, MPL, which make up 90% of MPN mutations, signal through the same common pathway, JAK-STAT, which is why the JAK inhibitors work in all of these. So whether you're JAK mutated, CALR, MPL, or triple negative, all of these patients signal through the same pathway, the wild type JAK-STAT. So just remember, even if you're JAK2 negative, that's why the JAK inhibitors work. So I mentioned 10% of cases will be triple negative, depending on where you are. If you're able to deep sequence these patients, you'll find something. Usually we find ASXL1, SRSF2, EZH2, some high-risk mutation that's likely driving the triple negative. Does it matter for prognosis? Absolutely. This is in myelofibrosis, a nice study in blood, which showed if you're CALR mutated alone, you have the best prognosis. If you're JAK2 or MPL, middle prognosis, and then the arrow, I'm trying to show you the triple negative, which means you don't have one of the three common mutations. You probably have a high-risk mutation like ASXL1. Those patients tend to do the worst, highest transformational leukemia, early stem cell transplant consideration. Let's look at each of the three in detail, and then we'll head to Q&A. First is essential thrombocytosis, or ET, largely skipped over in presentations like this, but no longer. In 2022, WHO and ICC, really no major changes from 2016, so you'll see me showing you both. Really, basically, there's 4 criteria for ET. Number 1, obviously, high platelets. 2, I emphasize you should do a bone marrow biopsy, whether older or younger, because you need to rule out reactive, you need to show megakaryocyte proliferation, you need to rule out dysplasia or MDS, and you need to check BCR-ABL. That should seem random to some of you. That's because you may find 1 or 2 patients in your career who have CML, so isolated thrombocytosis as the presentation of CML. And so one pearl I want you to get from this lecture is not all patients with high platelets will have ET. Check BCR-ABL, do a bone marrow, rule out CMML, RARST, AML with IDH mutation. Really check and make sure, because ET is a rare diagnosis. And then finally, 90% of patients should have one of the big 3 mutations, JAK2, CALR, MPL. It's pretty rare nowadays to have a triple negative ET, so make sure that's not some other entity. Okay, so you've made the diagnosis of ET. Worldwide, these are the same pearls, whether in US, Iran, Europe, anywhere, Asia. I want to emphasize again for our hematology colleagues on the line today, it's very common to see reactive thrombocytosis. So post-viral, post-surgery, post-COVID, make sure that we're doing a bone marrow biopsy to rule that out. We talked about the mutations. Of course, patients with ET have some unique manifestations. Scotomas of the eye, this kind of flashing curtain, vascular events, which can be very serious, so stroke, TIA. You can have a neuropathy-like syndrome called erythromelalgia, which is really a vascular event. And then you can have thromboses, either arterial or venous, usual locations, DVT or P, or unusual locations such as cerebral sinus thrombosis or Budd-Chiari. 2 pearls to remember: if the platelets go super high, let's say 1.5 million or higher, you're not at risk for higher clotting. You're already at a high risk for that. You actually become high risk for bleeding in a phenomenon known as acquired von Willebrand's disease. So platelets going high, you start to see bleeding, stop the aspirin, check von Willebrand's labs. You may need to admit that patient in the hospital. You need to stop the bleeding. Don't forget that although ET has a near normal life expectancy, people can still transform to one of the other MPNs or even AML. And I mentioned check BCR-ABL so you make sure you don't have CML. So again, ET, some of the longest studies are in Europe. Most people live a close to normal life expectancy, although I would argue, and you will agree, that if you're a 39-year-old person who has a left-sided hemorrhagic stroke and can no longer feed yourself, that's extraordinarily bad outcome that won't be registered on a survival curve. So the goal in ET is to prevent thrombosis, either the first one or the second one, watch out for bleeding, and just try to see if you can prevent or at least monitor for progression to AML. Scoring systems are still evolving. Most of you have heard of the revised IPSET, really looking at thrombosis in ET and endorsed by US NCCN guidelines. Simple, right? Age greater than 60 or higher, previous thrombosis. Now the newer systems add if you're JAK2, that should be the higher risk patients. Low risk or even very low risk. Question is, do you even need aspirin or not? I generally give almost all my patients baby aspirin at least, trying to prevent the first clot unless there's a bleeding contraindication or some allergy. Prognosis, I mentioned that most patients do overall okay with ET, although there is a small subset who have a lower than expected life survival. Professor Teferi in Mayo Clinic did this recent MIPS ET. I thought it was interesting because the addition of adverse mutations, so some of these splicing factor and TP53 mutations. If you look at this curve, there is a group of some patients who have high-risk ET. We all know, we've seen those patients in the clinic. They transform to MF quickly, so you may want to monitor them sooner. So recommendations for ET in the modern era, still the same essentially, Hydrea or interferon. I prefer interferon for most patients if there's no contraindication, possibly because we believe greater disease modification, but of course you have to watch for side effects, symptoms, etc. The other issue is baby aspirin for all, although there is this group of very, very low risk patients, you can argue that maybe they can just be observed completely. And of course, no role for phlebotomies with ET. Some of the studies ongoing in the US is to see in ET and PV, which one is better, right? That's the question we always get, hydroxyurea or interferon. I personally favor interferon products if there's no contraindication, but of course, Hydrea is easy, it's a pill, it's available, it's cheap. So far, the studies are just first few years, not necessarily showing a difference in complete response rates, but let's look to see if there's a difference in disease modification, thrombotic events, toxicities at 3 and 5 years together. So two good options for frontline therapy. Why does it matter? If you have hydroxyurea and ET and it doesn't work for you, resistance is actually associated with a 6-fold increase in death. All it tells you is if you don't respond to therapy, biologically, it's a more aggressive disease, likely to go to MF, AML. That's obvious. New therapies in the works. So a Ropeg interferon, trade name Bezremi in the United States, is actually already FDA approved 2021 for PV. But did you know at ASCO this year, my great friend and colleague Ruben Mesa, Lucia Masarova presented that the results are positive for second line ET, Ropeg interferon versus anagrelide. This may be new data to some of you. Primary endpoint was rate of response at months 9 and 12. The Ropeg arm was completely superior to the anagrelide arm. So in the United States, anagrelide is falling out of favor. Maybe it just physically helps the platelets to come down. But hydroxyurea or interferon is frontline options. Hopefully the Ropeg becomes available soon as a second-line option. The studies on ruxolitinib were mixed. We do still prescribe it off-label, particularly for symptomatic patients with ET. So notable AEs, all of us as hematologists should be aware. Interferons can have some serious side effects. Historically, when we did the 3 times a week, but perhaps a bit improved now down to pegylated interferon once a week and with Ropeg interferon every 2 weeks. I do a start low and go slow approach. So I usually start at the lowest doses possible, educate the patient and family. Yes, you can have psychiatric disorders, including even depression and suicide. Historically, it can flare up autoimmune disease, liver, thyroid, skin. I tell everybody. Some patients, after hearing it, say, hey, I don't want to have this, and that's okay. Start low and go slow. Titrate up a little bit slower than what the studies did and what the package insert says. Watch the patient closely. Really watch them for these toxicities. They can be serious. Hydroxyurea is not a benign drug, as you know. Leg or mouth ulcers, fevers, skin issues as well. Ruxolitinib, the 3 major ones I like to teach people. Weight gain can be significant, 30 to 40 pounds, probably through the leptin pathway. Non-melanoma skin cancer and risk of infection, most notably shingles or zoster. So much so are these side effects that almost all my patients end up seeing dermatologists at some point for the skin issues. And then if you can vaccinate people for the infections, if there's no contraindication. The weight gain is particularly interesting as there was recent data in US on patients who took the weight loss drugs, Ozempic, Mounjaro, the GLP-1 agonists, that possibly those patients do better on MPN. So we were eager to see more data on that. So for ET, I would just say before we move on to PVERA, lots of exciting research. Dr. Sorab was mentioning this. I'm actually shocked to be able to show you this. We have active phase 3 trials going on. LSD1 inhibitor, bomedemstat, keep your eye on that, a novel mechanism, epigenetic action. 2 registrational phase 3 studies, frontline ET high risk and second line If those are positive, they could potentially be a new strategy. BET or bromodomain inhibitors, Dr. Sorab mentioned that. And then, of course, the excitement here for us is the mutant-directed CALR mutant phase 1 and then mutant JAK2. I'll mention those at the end. Let's quickly talk about P-Vera before we go to MF. Polycythemia vera, no major changes in the 2022, so I'm still showing you the 2016. High hemoglobin or red cell mass. Bone marrow biopsy, I would argue, is still essential. You've got to rule out myelofibrosis, rule out ET. You need to show hypercellularity and panmyelosis. You need to rule out MDS and CMML, make sure it's not early transformation to AML. And of course, now in the modern molecular era, JAK2 V617F, or importantly, JAK2 exon 12. You may find one or two in a career that have that before you go down the secondary erythrocytosis pathway. Of course, all of you will know before molecular era, we used to use the subnormal or low or zero EPO level. You really should have all of these things to call it P-Vera, or at least the criteria, the major criteria. Exon 12, maybe this is a pearl I can teach some of the experts and colleagues on the line here. I love this. I try to teach this to all doctors and all people taking boards. This is New England Journal the year after JAK2, so 2007, so 2 years after. If you're still strongly suspecting P-Vera, before you start looking for obstructive sleep apnea, renal cell cancer, all those important things, check the JAK2 exon 12 if you have access or send out. This may be someone you thought was secondary or idiopathic erythrocytosis, but they actually have P-Vera. Okay, so P-Vera, you made a diagnosis. How do you treat it? So the triple therapy for the high risk, baby aspirin, phlebotomies for hematocrit goal less than 45, cytoreductive therapy, or for the younger or low risk patient, baby aspirin and phlebotomies. I think this is one of the great studies ever conducted in the MPNs. Seriously, New England Journal 11 years ago, 12 years ago. This is just phlebotomies. How much and what should you do? One group, whatever phlebotomies it takes to keep hematocrit below 45, the other group, it's okay. They had to stop the study early because there was a 4-fold decrease in cardiovascular events, including morbidity and mortality, in the lower than 45 group. In America, we were already practicing this way, but it was good to see this data from Italian group, which really showed the benefit of keeping your hematocrit below 45. The problem is most patients don't enjoy getting the phlebotomy. If you miss a few, then your hematocrit can go into 50s, 60s, and it's transient, right? It doesn't keep the hematocrit constantly below 45. So we need to improve on this. So right now in the modern era, 2025, worldwide, the standard is quite simple for P-Vera. Low dose aspirin for all, unless you have a bleeding or other contraindication. Phlebotomy, I recommend aggressively doing phlebotomy, no matter how much it takes to keep the hematocrit below 45. That's for low risk. If you're high risk, age 60 or higher, or a prior blood clot, add in cytoreductive therapy. Again, it's either interferon or Hydrea for frontline, ruxolitinib and Bezremi also available. Hydroxyurea is not a benign drug. I mentioned it earlier. You can have side effects from it. Some patients feel more fatigue on it, skin issues, fever, pneumonitis, ulcers in the legs and mouth. Once you get up to 3 and then 4 pills a day, almost nobody really likes taking this medicine. We need different medicines from Hydrea. As I showed you with ET, risk of progression, leukemic death is more if you fail Hydrea. I realize that there are some studies in people who believe Hydrea may accelerate the leukemia growth. We've never found evidence for that. It's probably the natural history of the disease, not the agents. So let's look at standard of care, at least in US. This is NCCN guidelines I'm showing you from last year. High risk P-Vera first. I have to emphasize, work with the cardio-oncologist. If you have at TUM system a cardio-oncologist or you can develop one, I would recommend it. We've had good success. So cardiologist who only sees our patients, managing the cardiovascular risk factors. So smoking, obesity, diabetes, very important. Aspirin, phlebotomy, cytoreductive therapy we mentioned. And then also people can have JAK2 chip, right? So that's a small VAF JAK2. So watch those patients carefully. The other issue to bring up is that clinical trial, if available, because these are rare diseases, but if not, this is in the second line setting. And then if not, then the ruxolitinib agent, if you have access to that, has now been approved for a decade in America, post-hydroxyurea. Here's the data for Rux and PV. It was already approved in MF. Big study, 1-to-1 randomization, 110 versus 112 patients with best available therapy. Patients needed to have phlebotomies and had to have splenomegaly. Crossover to Rux was allowed. Primary endpoint was dual endpoint. Okay, phlebotomy free, spleen should improve. Easily met in the Rux versus almost nobody in the BAT. and this got approved for PV a decade ago, post-hydrea intolerance or failure. Claire Harrison in the UK did a follow-up study, brilliant study in JCO just last year, in the last year. This is, again, Rux versus BAT, but this time it's investigator-led, longer follow-up. And what they did was a one-to-one randomization, again, Rux versus BAT, kind of a real-world study, 66 years old, median age. Everyone had prior hydrea, 180 patients, but median follow-up now 5 years plus. Primary outcome is CR in 1 year. This is the first study to do a lot of things. First study to show that if you normalize the blood counts, it matters. So this is with Rux. 2, EFS was improved, which I think should be a standard in our studies. Here they defined it as major thrombosis, hemorrhage, transformation, and death. That was superior with Rux compared to BAT. And for the very first time with Rux, that lowering of the VAF, here 50% reduction or more in JAK2, correlated with the best outcomes, improved EFS, PFS, and believe it or not, even overall survival. So at 4.8, let's say 5-year follow-up, they were able to show a separation in EFS and OS. People who got Rux had greater allele burden decrease, better normalization of the count, CHR, and better outcomes. We have never shown that as a field. This is a tremendous study and gives greater weight to ruxolitinib. So in NCCN for low risk PV has, I think, been a misunderstood disease. This is my own expert opinion to you. Yes, there are many patients who can do quote unquote well, but it kills me every time I see a young patient, 30 or 40-year-old with a stroke or heart attack. Could we have prevented that when we're just observing? Right now, the standard, as we mentioned, is baby aspirin and phlebotomies, but maybe there's a group of patients who needs treatment. And we do think clinical trial is a good option for these patients. Let's take a look at the data, particularly with the new ROPEG. So this is Professor Barbu in Italy, a beautiful study called the low PV study, looking at these patients, low-risk patients who would otherwise be observed. And here what you see clearly is that the ROPEG was given at a lower dose, 100. It can go up to 500 micrograms. All low-risk PV patients. The primary endpoint was median hematocrit level over the past year. And actually, the data was quite good. It favored the ROPEG over the placebo arm. Still a controversial study. It still asked the question, how long of a benefit, how long do these people need to take the drug? Is it really necessary in all these patients? So the data still needs to mature. The other big development in PV that I'm excited to share with my colleagues here at Tums, which I've been able to co-lead with my colleague, Dr. Andrew Kirkendall Moffitt, is that of the hepcidin modulators. I think this is going to be an important development worldwide. So the concept here is hepcidin is the chief or master regulator of iron homeostasis in the body, and hepcidins are pathologically low in P. vera. When they're low, it allows the blood and the iron to accumulate too much in the blood, leading to high hematocrit, leading to phlebotomies. When you give one of these agents, they can either mimic hepcidin or modulate it to make it higher, tell the iron in the blood to calm down, go back into storage, no more phlebotomies, patient feels better. That's the hypothesis. I'm proud to tell you that this worked. In the first-in-class agent that we tried over the last 5 years, known as rusfertide, PTG 300, in the phase 2 study known as REVIVE, we've shown in multiple conferences now and published that this weekly self-injectable, patient gives it themselves, led to phlebotomy free in almost 70% versus only 15% who had only phlebotomies. And this was actually well-tolerated drug. So much so that we were able to publish the phase 2 non-randomized already in New England Journal, and it was well received, but not enough to get approval. So we had to set out to a randomized phase 3. I'm going to show you those results hot off the press. So this was presented at ASCO plenary session a few months ago. Phase 3 rusfertide placebo-controlled randomized worldwide study for P. vera. This is known as the VERIFY study. This may be the first time you're seeing this data. So the new agent rusfertide, that's the weekly self-injectable hepcidin mimetic, plus whatever therapy you're on, current standard of care, hydrea, Rux, interferon, versus just phlebotomies, placebo, and whatever you're on. 56% of patients had a concomitant therapy. Crossover is allowed to continue on rusfertide. Primary endpoint is at weeks 20 to 32. You had to be phlebotomy dependent PV to get on the trial. So 3 or more phlebotomies in the prior 6 months, fine, or 5 or more in the prior year. Not everybody is like that. So we had screen fails, right? You couldn't get on the study unless you met this. I think it's pretty rigorous. 1-to-1 randomization. So again, the primary endpoint for the US is weeks 20 to 32, how many clinical responses you have, which is defined rigorously, absence of phlebotomy, eligibility, etc. Key secondary endpoints, there were 4. How many phlebotomies did you need? Proportion of patients below 45, and then 2 separate fatigue symptom score scales so that there would be no doubt if this works or not. Very, very high level rigorous study, actually. All right, let's take a look at the data. So almost 300 patients enrolled, median age, maybe a bit younger than the usual real world, so around 57, 58, but up to 86 years old. So that represents real world. Some of these patients needed a lot of phlebotomies. In the rusfertide arm, there were 16 patients who needed 7 or more therapeutic phlebotomies before getting on the study. So you can't argue that this is a real phlebotomy-dependent crowd. Overall, the primary endpoint was met. Let's review that. So 77% responders in the rusfertide plus standard of care versus 32%, 33% in the placebo control. This was p-value highly significant. Treatment emergent events, very well tolerated, self-injectable. I should point out a few things. There were injection site reactions, which led to a little bit of skin issues in the beginning. They were transient. Some patients overshot and became anemic, so maybe the drug working too well, needing dose reduction interruption. There was one thrombotic event so far with short follow-up, an acute MI that occurred 2 weeks in treatment. Okay, maybe natural history of the disease. Discontinuation rates very modest here. So overall, I would argue to you a well-tolerated drug clearly met its primary endpoint. I didn't show you the data. It met all key of those secondary endpoints. So fatigue score, symptom score, p-value improved, all of those things met. So for a primary endpoint and all key 4 secondary endpoints. So even though kind of short follow-up so far, this phase 3 was wildly positive, as you saw. And so hopefully we're going to be able to have this considered for regulatory approval this coming year, 2026, and we'll update you in future meetings. So for polycythemia vera, before we close with MF, Dr. Sorab, Dr. Marjan, and colleagues, I want to leave the colleagues with some pearls that I've learned over the last 20 years. If you're suspecting PV, everyone knows about JAK2 V617F, but don't forget about the JAK2 exon 12, highly rare. You may see 1 or 2 in your career. Don't forget to check it before going to secondary erythrocytosis workup. In the secondary erythrocytosis workup, I've diagnosed a lot of people with obstructive sleep apnea in America. They came to me as a cancer doctor. They thought it was going to be blood cancer. Bone marrow is completely negative. Yes, we do things backwards sometimes. It ended up being sleep apnea. So look for heart conditions, lung, renal cell, and hepatic cancer can produce a paraneoplastic EPO, which can then look like P. vera. So imaging, scans, you don't want to miss something like that. And then the final point is that the very young person, the teenager or adolescent young adult, first presentation can be a blood clot in an unusual location. So think about the young person with cerebral sinus or liver, Budd-Chiari. Check JAK2, CALR, MPL, bone marrow. You'd be surprised. You may be the first person to see them with an MPN. And so the last thing I'll leave you with PV before we go to MF, I think actually an important point is hydroxyurea or interferon as the front lines. But don't forget also about the new Ropeg interferon once it becomes available to you, and then ruxolitinib as second line. And then, as I mentioned to you, a lot of exciting clinical trials in PV. The one that's exciting, of course, is the mutant JAK specific therapies. Okay, and then briefly, let's talk about myelofibrosis before we open up to questions. Myelofibrosis is a tricky disease, can be a low risk, intermediate 1, intermediate 2, high risk, very heterogeneous, I think a very difficult disease to identify and treat. So let's do the bone marrow biopsy, megakaryocytic proliferation and atypia, collagen fibrosis or reticulin fibrosis, grade 2 or higher, very important. If it's grade 1, we're calling that now prefibrotic MF. If it's 0, then it's probably ET or PV, right? Early MPN. Again, make sure you're ruling out ET, PV, CML, MDS, CMML, everything else. And again, 90% of these patients will be JAK2, CALR, MPL positive. If not, look for the other ones like ASXL1 to see what's driving it. The minor criteria you'll remember clinically are important: the teardrop cells, leukocytosis, splenomegaly, LDH. You can't diagnose MF just based on this, but these are minor criteria. All right, so you made a diagnosis of myelofibrosis, but my goodness, what a heterogeneous. Those curves tell you. If you're low risk, you're measured in decades. You may just need observation, maybe EPO, maybe just nothing, right? If you're intermediate 1 and some high-risk feature, you may need treatment and a stem cell transplant. You may need observation. But once you get to intermediate 2 and high risk, your overall survival is less than a decade. You need some intervention there. Scoring systems, as you know, IPSS, which I love, that was Cervantes Blood 2009. It's really meant to only be at diagnosis, but can be done quickly at the bedside. Age greater than 65, white count greater than 25, constitutional symptoms, percent blast 1% or higher, anemia. The problem is it's not dynamic. And so the DIPSS was invented where you can use that anywhere, weighting the anemia greater. So if you're wondering what's the difference, hemoglobin less than 10 gets 2 points, everything gets 1 point. Then the DIPS plus and MIPS. MIPS is important because you have molecular mutations for the first time added, and a lot of us use it. There's an online calculator you can use from this JCO paper. Why does it matter? It matters because we need to know what to do with these patients. If you're intermediate to high risk, you qualify for JAK inhibitor, you should be considered for stem cell transplant. If you're low risk, you may not need those things. So let's review the 4 JAK inhibitors Dr. Saurabh mentioned in his nice comments to introduce the topic. Ruxolitinib, as you all know, first-in-class drug, JAK1, JAK2 inhibitor. Again, let me emphasize for the colleagues, experts here, even we get confused or questioned sometimes. It's not a JAK mutant inhibitor. Those are coming now. JAK-STAT pathway inhibitor. So intermediate to high-risk MF, Comfort Trials, New England Journal, over a decade ago. Number 2, approved in August 2019, fedratinib. This is a JAK2 inhibitor, but also has a FLT3 and other activity. So pay attention to these JAK inhibitors that are not all created equal. This is also approved in intermediate. I think intermediate 2 high-risk MF is the specific one. Jakarta 1 and 2 studies. And this one was first time we saw activity of a JAK inhibitor post-ruxolitinib. So either frontline or after Rux can improve the spleen and symptoms, but Wernicke's encephalopathy is the major black box warning. Pacritinib was approved in February of 2022. JAK2, but also FLT3 and IRAK1 inhibitor. Interesting drug. It got the accelerated approval in the US for platelets less than 50, so I realize not available all over the world yet. It's actually pending the confirmatory trial, right, Dr. Saurabh, of the Pacifica phase 3 trial, so we eagerly await that. But it's a nice one to have in the armamentarium, platelets less than 50. Finally, as you mentioned yourself, momelotinib, a game-changing, exciting one, JAK1, JAK2, ACVR1 inhibitor. Why is that important? Because ACVR1 is probably what helps to improve the anemia, whereas the fedratinib and Rux can make it worse initially. And this is the momentum study, which I will show you. Okay, so let's look at Rux in detail. Again, a lot of us know this data, but it's good to pause and look at it. Comfort 1 and 2 studies led by Verstovsek, Harriet Anderson, and Claire Harrison in Europe. I'll show you the Comfort 1 here just to level set for the rest of the drugs. This was a game-changing big study. New England Journal. At the time, there was no standard of therapy, so the control arm literally was placebo, which seems kind of bizarre now, but that was correct back then. What they did is ruxolitinib BID drug based on platelets, as you know, 155 patients versus 153, and it greatly improved over almost no responses in the placebo, 42% versus just under 1%. They had to make up the endpoints there. So SVR 35, spleen volume reduction, 35% or more by imaging or 50% by palpation. And then symptom score, TSS, total symptom score 50, both of them at 24 weeks. These were arbitrarily set by the investigators. We now use them moving forward. I love those kind of stories. How did those response criteria come about? All right, so the ruxolitinib was wildly positive for both primary and secondary endpoint, first in class approved. But what does it really do? What it does is it makes people feel better more rapidly than anything I've ever prescribed in my clinic over the past 20 years. Now, this is from these comfort studies. You started to see response, as you all know very well, within days and weeks. Huge spleens and livers shrinking, people in wheelchairs coming out. It's remarkable. Looking at the waterfall plot, now this is Comfort 2, which was against best available therapy. The other one was placebo. Almost all patients responded. They almost all responded quickly and durably, but you have to watch out for cytopenias, weight gain, infections, etc. Well, the dose matters for ruxolitinib. You're supposed to dose it based on the platelets, but honestly, many of us dose it on other factors, anemia, patient preference. A lot of people end up getting 5 twice a day, 10 twice a day. It turns out that's not the best thing. If you can get it to the best dose possible, meaning the highest and best and most durable spleen response, those people do better. Even overall survival is improved. Real-world analyses, including our own, are showing that survivals are improving in myelofibrosis, and it's literally due to this drug and the class of JAK inhibitors. The pooled analysis from both Comfort 1 and 2, the two studies I showed you, indeed, even though it was not a pre-specified statistical endpoint, it's showing overall survival benefit. The second drug is fedratinib that I want to show you. Fedratinib is the other JAK inhibitor we mentioned. Huge international effort, Jakarta 1 and 2 studies. Again, to emphasize that the fedratinib 400 milligrams POQ day was ultimately FDA approved in the US for spleen and symptom improvement, frontline and secondary. But you have to know about the safety signal. First thought of as Wernicke encephalopathy, later revised to encephalopathy in general. GI, nausea, vomiting, diarrhea. This is a black box warning, meaning you have to tell the patients, we give prescription for thiamine up front, check the thiamine for the encephalopathy, give a prescription for nausea, vomiting, diarrhea. You really have to watch this drug carefully. The third drug is the pacritinib that I mentioned, approved in the US, accelerated for platelets less than 50 based on PERSIST 1 and 2 studies and the PAC 203 dose finding study. Ultimately, the PAC 200 BID was ultimately FDA approved. All these drugs are fasting. This drug was suspended for a little while before approval for worry of bleeding and cardiac signal. Later, my group and others showed that that was not as major of a signal as previously thought. So it's now approved, but you should watch out for cardiac and bleeding in the real world setting. Does PERSIST-2 work on the spleen and symptoms, the pacritinib? Yes, it does. You have to watch out for GI side effects, usually diarrhea in the first 2 months, and then this cardiac and bleeding signal, especially because we're giving it to patients with low platelets. The next final JAK inhibitor of the fourth one is momelotinib, approved just 2 years ago, right, guys? September 2023. This is a cool study. I want to show you this in detail. Previous had a JAK inhibitor, but you're still symptomatic and anemia. And it's a 2-to-1 randomization, 200 patients after your washout from your previous JAK inhibitor. And you're looking at momelotinib, 200 milligrams daily, the final dose that got approved, plus placebo. Okay, it's a double-blind placebo study versus danazol and placebo. Everyone can cross over to the study drug. The primary endpoint is remarkable. For the first time ever in the field, symptom score at week 24, interesting. Key secondary endpoints, transfusion independence, spleen response rate. And then if we just look quickly, yes, transfusions improved, anemia improved, well-tolerated agent. You have to look out for peripheral neuropathy. You have to look out for GI, nausea, vomiting, diarrhea. Of course, the counts can go too low, as with any JAK inhibitor. And you have to watch out for liver and kidney, but it's been a nice drug in the clinic. Briefly, just a few minutes, Dr. Sora, before I turn back to you. Prognosis after Ruxo is actually not as good as people think. You go from a chronic disease to acute. Here, what I'm showing you is that patients who fail the ruxolitinib often develop clonal evolution, cytopenias, worse disease biology, and can have an overall survival of less than 2 years, regardless of where they started. Our Italian colleagues showed in a large retrospective study, 218 patients, that really almost half of patients are off Ruxo at 3 years. And we all know that in the clinic. Nobody talks about it, but we know these patients aren't all on these drugs for decades. Most of the reasons for coming off are adverse events, bad things, infections, loss of response, transformation to AML. And when you come off of Rux, your overall survival can only be 1 to 2 years. The only thing they found was use of investigational agents associated with improved outcomes. So my group and I said, what can we do to improve these outcomes, guys? 3 things we put together in this major white paper. 1, can we intervene earlier in myelofibrosis before it gets too late? 2, can we combine a drug with the JAK inhibitor, something beyond JAK-STAT pathway? 3, can we give novel agents, immune therapies, something new and different? The original immune therapy is allotransplant. This is the only curative therapy for myelofibrosis. Let me repeat that. It's the only curative therapy we have so far. So, but most of our patients are older, frail, cost, logistics. We know all the barriers there. I would say only 15 to 20% of my patients go for transplant. So if allo is available, please send your patient, but we know most of them can. So looking at novel agents, we used to borrow from AML and MDS, but I'm proud to tell you this figure, which we made a few years ago, is already expanding. Dr. Sorab mentioned my work in a related field, BPDCN. We got the drug approved, CD123, FDA approved. We're working on the second generation one. Maybe this has activity in these MPNs. Antifibrotic agents, anti-CALR, JAK2, BCLXL, BCL2, MDM2, et cetera. So even though you may not have access to these drugs, I think we need scientists and colleagues working around the world, on these exciting pathways. One that has worked out clinically, I'll show you here at the end, is that we can combine drugs with JAK inhibitor for the very first time. We started out doing with hypomethylating agents, thalidomide, lenalidomide, some actual activity there with those non-modern agents, if you will. But now moving into the modern era, we have ongoing phase 3 trials. Pelabresib, which is a BET inhibitor added to Rux, luspatercept, which is an anemia-improving drug, MDM2 inhibitor, navtemadlin, XPO1, selinexor. The most important of these is the pelabresib. The Manifest-2 study is ongoing. This is a huge study, second largest in the field. Pelabresib and Rux versus Rux and placebo, with primary and secondary endpoints, what you would expect, spleen and symptoms. So far, the spleen has showed heavily positive in favor of the combination, but the symptoms didn't quite hit p-value significance, just missed it. So they're following long-term, and now the data has been presented 72 weeks. We hope to see 96 weeks at ASH, that it continues to show long-term benefit. So we hope that combinations like this might be available. The second one is selinexor, XPO1 inhibitor. It's in an ongoing study called Sentry, which is now completing accrual, so we eagerly await those data. And another exciting one is add-on to ruxolitinib with a new agent called navtemadlin, NAV, which is an MDM2 inhibitor, the so-called POISA study, which is actively enrolling around the world. So very important we support this study. In the relapse study, there is one phase 3 important, which is imetelstat, the first-in-class telomerase inhibitor. Why is this important? Because it's the very first study in the field to put overall survival as the primary endpoint. So I personally am eagerly awaiting these results. The future is bright in our field. I think targeting CALR is very important. EHA meeting this summer, the first data on a CALR monoclonal antibody was presented in ET patients, showing encouraging, very nice data, but early on in phase 1. So we need longer term follow-up. And there's another CALR program, the J&J bispecific CALR by CD3, available for ET and MF. We await those results. Targeting the JAK2 mutation is very exciting. There's two approaches there, the AJAX, as well as this Insight mutant JAK selective. Those are in ongoing phase 1 results, so we hope to see data on that. So I would conclude, team, by saying there's so many exciting developments in the MPN, really around the world in the rarest of rare diseases. And what I would say is that we need to look for new agents, new approaches, including harnessing the immune system to do that. And with that, I'd like to thank all of my friends and colleagues around the world. Dr. Sorab, Dr. Marjan, let me turn it back to you for some Q&A.
Thanks a lot, dear professor. It was really an exciting and it was really a great lecture. A lot of new drugs on the way and a lot of achievement in the past few years. And thanks a lot once again. And let's go to the question part. The first question is, I want to sum them up. The first question is that one of our colleagues said, is it time to say goodbye to the Anna Gerlit in ET? I think that she is talking about the Surpass ET study. I think
Yes.
that she is asking about that head-to-head study of ROPEG to the anagerlid, because we have a lot of problems with anagerlid, increased fibrosis of the bone marrow,
Yes.
and not really that much effective old drug, a lot of complications. Is it time to say goodbye to anagerlid, in your
Yeah,
opinion? What do you think?
I largely agree with that comment. I think in addition to the nice points you brought up, I've had patients have heart block, so cardiac problems, CHF with anagrelide, headaches. It's a tough drug to give in some patients. Obviously, we have to be mindful of worldwide audience, such as this one. It is a cheap drug. It is an available drug. It does physically bring the platelet number down, and sometimes you just need that, right? High platelets, etc. So rather than saying goodbye to anagrelide, let's put it down as the lowest on our armamentarium. I look forward to the day where we have dozens of therapies and we can say a final goodbye to it. So let's only use it in emergency, last resort situations. But as you guys point out, we have much more active drugs that lead to disease modification. Really, in the modern era, the only time I can see anagrelide used is an emergency situation, platelet of 2 million. You're looking for anything to help bring it down.
Okay, thanks a lot. Another question that one of our colleagues asked us is about, do you treat patients with CALR1 and CALR2 mutation in the same way? Or you treat such these patients differently, CALR 1, CALR 2. In your common practice, do you check for the CALR 1 and CALR 2 mutation, or you just check the CALR mutation? In Iran, we do not have that, and we just check the CALR. I don't know
Yeah.
whether CALR 1 or CALR 2. What do you
It
think about
it may
that question?
theoretically matter. So for you guys, it's good that you're checking CALR because all you really need it for right now in the clinical practice is diagnosis, which helps you to confirm you have an MPN, because once you have CALR, you know it's not reactive anymore. And then two, prognosis. As I showed you, if you're CALR alone in ET and MF, it appears that that's probably associated with a better prognosis. Type 1 versus type 2 is academic debate still. There's some debate in the field that one is worse than the other, one is associated with more clots. But on the clinical trials, interestingly, we allow both type 1 and type 2. So insertion and deletion, I can tell you, you probably will see responses with either one. So if that's all you have, it's okay. It eventually, yes, let's check type 1 versus type 2, VAF, but we need to show you that it really truly matters with regards to treatments and not just theoretical retrospective chart reviews.
Thank you. I've just seen an algorithm that has been proposed by Professor Teferi.
Yes.
In that algorithm, he said that if the patient is less than 6 years old, MPL or CALR1 mutation, you have to use aspirin. According to old data, less than 6 years old, no JAK mutation, almost nothing. We can just forego and not use even aspirin for such these patients. But in that algorithm, what I had seen is that for MPL and CALR1 aspirin, for triple negative and CALR2, he said that if cardiovascular risk disease is positive, we have to use aspirin, and if it is negative, we can just forego aspirin. Do you agree with that?
Not particularly. I think in the US, almost nobody uses that particular specific detailed algorithm. It's still being debated and discussed. In the real
Yes.
life setting, we have patients who have clots and thrombotic despite all of these machinations and things. So I would keep it simple in the clinic. I think if you're ET and you're younger than 60, no prior clot, unless there's a contraindication, I think the vast majority of patients still benefit from a once-a-day baby aspirin. Now, the problem is some of these people develop peptic ulcers, bleeding that they don't know about. So you really have to follow the patients. In PV, low risk or high risk, I think everyone still needs a baby aspirin. So I would actually really encourage, unless there's a real reason not to give aspirin, my personal preference is to do it because I am pretty aggressive. I want to try to prevent the first clot from happening. I don't think we can predict that yet based on all these factors. And there's also cardiovascular risk factors. People have overweight or smoking or other things. So unless there's a real contraindication, let's acknowledge that there's an academic debate. Let's acknowledge that there's probably a group of super low risk people that may not need aspirin. And let's acknowledge that there's a group of people that if you give aspirin, you may cause bleeding, but those are very rare patients. More common is someone having a blood clot and catching you off guard. So I would give that kind of guidance to keep it simpler.
Thanks a lot. The other question is, according to the MAGIC PV trial, the robust molecular response by using ruxolitinib had correlation with better PFS, better OS, deeper molecular response,
Right.
better clinical response. Do you think that maybe in the near future, instead of using hydroxyurea as a cytoreductive agent for patients with PV, ruxo will come to the first line?
What a great question by the colleagues. Excellent question. Yes, I do believe that. That's my personal belief. I love what you said, exactly what you said. Just based on that one study, Magic, really, this is what we need to be doing as a field. There is the Ruxo Beat program study by Stefan Korjmeier in Europe. I didn't show you. So that's an ongoing study trying to move Ruxo closer to the front line. We'll eagerly await those results. But it's a great point. Now, what we need to do as investigators in the field, myself included as one of the leaders, we need to push folks to do that. I think also very exciting, there's, basically what you're talking about is disease modification. If you can show that exciting disease modification after Hydrea, why not move it to the front line? So I favor that. We favor that as a group. We need to do those studies to show that.
Is there any ongoing study exactly the same way like Magic PV for ET using Ruxa in head-to-head study for hydroxyurea. Is it any study like that around the world?
Yeah, I should have mentioned. Yeah, so we did do, so Claire Harrison, Professor Harrison also did Magic ET. So that was already published before, two studies. One was positive, if you will, one was neutral or negative. And so it did not end up getting approved in the second line setting. But what was found in the waterfall plot is that if you're ET, you had hydrea before, you're still symptomatic. I have a lot of those patients in the clinic. Those folks really benefited from ruxolitinib. It improved their symptoms, just like we see in PV and MF. So at least in US, and I have to emphasize this is off-label, can't recommend it, but you should at least know that we commonly prescribe off-label ruxolitinib ET based on those studies, even though it didn't gain the FDA approval.
Okay, thank you. One of the other colleagues has asked, what is the role of luspa in the treatment of myelofibrosis in combination with ruxo?
Mm.
What do you think of that?
These are such great questions. So I have to tell some bad news first. There was a press release. So just press release. So it's released as top line results. This is publicly available, what I'm telling you, so it's not secret. But just a few days ago, a few weeks ago, it appears that the top line results of the independent study, so Ruxo plus luspatercept, will not be positive. So will not be positive for all comers. So that's a bad news for the field. But let's await if there's ASH abstract or Congress results, whatever's coming. We're not sure yet. Maybe there's subgroups who benefited, maybe they didn't. Okay, so we know the top line results, but I want to say 2 points to that. One is that in myelofibrosis, the luspatercept is already approved, and we know that it can improve the anemia, although with some side effects there. And two, again, I guess I should emphasize again, in US, there are situations where there's what's called off-label approval. If we believe it can still cause benefit for the patient, justify it, show the literature. Let's see the full data for LUSPA. If it's really truly negative, are there still some subgroups that may benefit? Really severely anemic patients, somebody else. And then if not, then what I think is the anemia still remains an elusive, urgent goal. You have the momelotinib, which can improve anemia. Pacritinib also possibly may improve anemia, also through ACVR1. There's new drugs like elritercept and others. So I want to say for the LUSPA, let's await the final data, but the overall top line is bad news so far. Let's see what the full data shows.
Exactly. Many of the drugs in the MDS field are coming to the MPN field. Luspa, imetelstat,
Brilliant.
all of them are coming also here. Another
Cool.
question is,
Oh,
what is your Thank you. What is your recommendation for a patient diagnosed with myelofibrosis who had 15 to 18% blast in the marrow and after treatments with aza-ven? Now he has 5% in the marrow. I would like to know if we should continue the treatment and what do you recommend? What would you recommend for this patient?
how old
The
is the
patient,
patient? Do they tell us?
Professor Tawakkol did not tell us if she's online.
Okay.
Would you please tell us? I think I don't know
These are older and
whether
younger.
it is old or young. Yeah, because
Yeah.
if he or she is young, he should go to the transplant. I think
Yeah.
maybe the patient is old.
Exactly.
I don't know
Exactly.
what did she mean?
Yeah, so we'll go
What do you
through both
think of
scenarios.
that?
Yeah, we'll go through both. So the younger patient or fit, however you want to define, this patient has a super high mortality. So at least in US and culturally, it may be different in other places, but you have to tell the patient up front, this is really one of the worst situations we have. So AZA, Ven, whatever you did as first line approach, fine. It's not going to keep them. This patient will die in the next year. We know that or less. So I like transplant as first option. Let's suppose they say, well, I can't go to transplant for whatever reason. Then it's interesting. So actually, our group and others have shown that Ven, this may be the one place where Ven is not as highly active in the myeloid. Actually, well, MDS actually it's showing that too. So whereas in AML, Ven appears to be active, we have shown that BCL-XL may be more active in MF. So navitoclax, which unfortunately did not get approved. So, but fine, everyone uses HMA-Ven, chemo-Ven, because that's what we know. But I would actually say if you cannot get to the transplant, fine to do AZA-Ven, whatever you're doing, but also you may want to add in the JAK inhibitor as well, right? So you can we've published on AZA-Ruxo before in patients with either chronic phase or accelerated blast phase, such as this patient, or you could do a triplet if you're really feeling daring, right? So Ruxo, AZA-Ven, although you have to watch out for myelosuppression. The second approach is chemotherapy, which is not everyone's favorite answer, but you could induce as an AML if they still have high blasts, cladribine-based approach. Here, this patient went down to 5%, so you'll favor an outpatient maintenance. So here, if you're able to go to transplant, let's do it. If not, repeated cycles of HMA-based, which clearly got your blast down, but not as a final strategy. And then if they start to progress again, cladribine-based chemo, put them in the hospital for AML induction, high mortality rate.
Thank you. About the last question, our colleague said that until the transplant, I want to know about your recommendation. My patient is triple negative. She said that she wants to take the patient to transplant, and I think that her question is that you should continue it as a bridge to transplant. What do you think of that? I think we should continue it, yes?
Yeah, triple
Dr.
negative has to go to transplant if you
Same
can.
question.
Oh, go ahead, Dr.
Exactly.
Marjan.
I think Dr. Sahar mentioned this about the last question, that the patient is triple negative, and the question is during the time for the waiting to transplant, she wants to know your recommendation about the treatment of these patients. The last question is the continuing of the last.
Continuing, yeah, same thing we were saying. Yeah, so maybe just to emphasize, whether they're triple negative, whatever's going on, if you got the blast down from 15 to 18% down to 5%, it works. So continue cycle 2 of the same. I would do a total of 2 to 3 cycles at max before, try to go to transplant as soon as possible. If it's being delayed, 2 to 3 cycles, repeat the bone marrow. And then again, as we said, if the blasts are going back up again, I would now switch to a cytotoxic chemo regimen. So cladribine based. We have an ASCO abstract from Masarova and Kadia with me. And then the other issue is, are there any other active clinical trials or agents? If you have access, great. But we have to emphasize this is the worst and toughest group with unmet medical need. There's no FDA-approved strategy for these patients. For example, CPX-351, Viexios, did not
Yes,
include
yes.
these patients. It only included MDS to AML.
Yes. Do you also add Ruxo for these patients to make the
Sometimes.
spleen much more smaller to have a better result in the transplant? Yes, you also add Ruxo, yes, or
I do.
RT of the spleen.
I do, but it's controversial in some patients. So you can add Ruxo. The question is it going to lead to increased immunosuppression or not? Some of these people lose the JAK2 clone, but if you can do a tapered Ruxo and include it pre and post transplant, right? It has activity against GVHD, but that's tricky to do. Yeah, you have to have a protocol with that.
Thank you. One of our great colleagues, Dr. Amir Abbas Rashidi, said that can a patient in the prefibrotic or early phase of primary myelofibrosis present with massive splenomegaly, or is such extensive splenic judgment more typical of overt fibrotic stage? What do you think of that?
Yeah, you can, right. So every once in a while, we're surprised too. Usually when someone has splenomegaly and cytopenias, it usually comes out as MF2 fibrosis. But there's two scenarios where it will be pre-fibrotic. One is the patient just shows up super early in their disease progression. And two, I hate to say it, but our pathologist will agree with me. Sometimes it just depends on the sample, the patchiness, the person reading it. There's a little bit of variability between MF1 to MF2. So the reason why this is such a great question is we all know that if you have a big spleen, you probably have MF2 myelofibrosis, even if the bone marrow doesn't show it. So in those cases, again, MF1 to MF2 interferons work very well. There's data from Harry Gill out of Hong Kong, which shows a lot of good activity there. JAK inhibitor to shrink the spleen down. And then, of course, repeat the marrow, and it'll likely show MF1 to 2 on the repeat.
Thanks a lot. Another question. I think that we have only about 5 minutes.
Yes.
Excuse me for taking your time a lot. Yeah, one of our colleagues has said that in patients treated with interferon, what is the recommendation interval for response evaluation, both clinically and hematologically? And how often should we assess for molecular response or mutation clearance of JAK2 V61F allele burden? What do you think of that?
I just had clinic yesterday. We talked about it. So, of course, there's two answers. Hopefully, no one will get too frustrated. There's the academic answer, which, of course, we love to say follow and all that, but there's also the real world answer. So, let me give the real world answer first. We're not on clinical trial, whether you're in Tehran or Houston. We really don't follow these things as closely as the patients expect we would. This is not CML where we're monitoring for this. And number two, my most dreaded scenario is you check it and the allele burden is actually going up, but patient is doing great, blood counts are okay. So yes, you can look at Conti PV and Proud PV study of ROPEG, median follow-up of 7.5 years. Yes, they check the allele burden and bone marrow, but in the real life clinic, may I give three practical, and I think the colleagues here will appreciate it. If the patient is doing well, and I really mean well, blood counts are doing well, symptoms, we actually do not anymore check routine bone marrow. This may be surprising to you. We used to check it yearly or every 6 months. We don't do that anymore because it doesn't show much. Two, if there is any change in the patient's symptoms, blood counts, something is different, then we do a bone marrow at that point. And then three, even though I'm the biggest fan of allele burden, I've been publishing on it since 2006, 20 years ago, it really doesn't always correlate with the patient response and can lead to some frustrating scenarios and can cost a lot of money. So possibly it may be a popular answer, but not what you expected. I would stick to the practical clinical things with the patient on interferon: side effects, toxicity, blood counts, spleen, symptom control. If you do that, you only do a bone marrow if there's a big change. That's the practical answer in real life.
Thanks a lot. And I think that we do not have that much time. And the last question is one of the questions that at least I have, because I had one of the patients, and I know that you are the greatest person maybe in the world for treating patients with BPDCN. What I want to ask you is that in patients with BPDCN, we all know that maybe the cell of origin of BPDCN is the myeloid lineage, you know,
Yes.
and I know that there are clinical around the world, especially in your center, about using hyper CVAD plus tag, maybe azaven plus tag. I don't know that exactly. But the question that I have is that why do you even try hyper CVAD? These are the myeloid lineage cells. Why do you use hyper CVAD? The first question. And the second question is, when we do not have access to tag, what should we prescribe for our patients? Tag is not available in our country, and what are the other options? The old chemo regimens. I know that all of the old chemo regimens, the median OS was about maybe 8 to 12 months or even less than that. What do you recommend? And I know that maybe you use hyper CVAD because of the sanctuary site of the involvement in their brains. Maybe it's because of that. I know that. But they come from the myeloid lineage cells. Why do you even try hyper CVAD plus tag for such these patients?
Good. So the first question, everything you said is 100% correct. So BPDCN is a plasmacytoid dendritic cell PDC lineage tumor, which we think is myeloid derived. So that's correct. But myeloid chemotherapy doesn't work as well as lymphoid. So one reason for that is it's a hybrid disease. A lot of these patients are TDT positive. They'll have MYC rearrangements. So they actually have features, not only clinically, but biologically, of both myeloid and lymphoid. I think that's more helpful to think about. Even though it's myeloid derived, it has properties of lymphoid as well. The second part is what you said. Clinically, when we looked at all the regimens, hyper-CVAD plus VEN, hyper-CVAD plus VEN tag appears to be superior because it crosses the blood-brain barrier. It's exactly what you said. 30%, 20 to 30% of BPDCN will have CNS involvement. We missed that. The only reason we found that is because with tag and VEN, they don't cross the blood-brain barrier. So probably hyper-CVAD works because BPDCN does have lymphoid properties. It can involve the lymph nodes, and it crosses into the CNS so easily and regularly that the hyper-CVAD, better than myeloid chemo, better than targeted, helps to not only treat that, but actually it prevents CNS. So since we started adding hyper-CVAD, we're having good outcomes. The rest of the world who doesn't have CD123 therapy, younger patient, you'll do well to give hyper-CVAD VEN, or older patient, you can give HMA VEN and be okay that you're not giving CD123 therapy. Yes, that adds to it, but you can still treat. So that's the answer.
So in our patients, when we do not have access to tag, we can use azaven, yes?
Older
The only
patient,
option.
older patient, resource challenge place, ex-US, aza-ven for the older unfit patient, PS of 1 to 2. Younger fit patient, hyper-CVAD ven if you have access to it. Allo transplant and CR1, and then lumbar punctures. Do 8 lumbar punctures in everybody, so 2 by 4 cycles, even if you're giving aza-ven, right? Because neither of those cross the blood-brain barrier. And then that would be a nice lack of CD123 therapy. You're still doing your patient some good there.
you just make up another question. Do you use TBI for your patients when you want to perform transplant because of the involvement in many sites in the
TBI is
skinny
good.
brain?
So yeah, that's maybe one of the few developments I didn't lead in the field. So it's good. CIBMTR is the recent paper last few years. That's a good approach. Exactly why you said. Probably it helps to decrease extramedullary sites. At MD Anderson, if you look at our paper, Kaiser, Bashir, and Kazelbosh and myself, a few years earlier, we use flu-bu regimen or flu-mel, right? The old standard, good old knock you down myeloablative, and we have super great results. I will say though that majority of our patients in that series are younger. Now in the latest, which we need to republish, we've been transplanting older patients, 60s, 70s. So either approach is good. Either TBI, CIBMTR endorsed, or our old school flu-mel, flu-bu, which is what I prefer. So you have some options there.
Thanks a lot. Really a great lecture and a lot of new information.
Yeah, this was great.
And I hope that we can see you as soon as possible again in the near future. And it has really been an honor for all of us to have you here and generously give us a lot of information about new drugs, new treatments, and the way we should use them in clinical practice, not only yes, that's the point, because in real practice, it is really something else. We cannot check allelic burden. There are a lot of problems we have. And I just thought that maybe in the United States, you do not have too many problems like that, but it seems that you have the same problems because of the logistics and things like that. And thanks a lot. And I hope that we will see you as soon as possible and in the near future.
What a great honor. Thank you, Dr. Marjan.
For that insightful talk, and have a great day. Have a great trip.
Thank you so much. You guys are the best. I really appreciated this time. Thank you. What an honor. Thank you all.
Thank you. Stay safe and sound.
Thank you. You too.
Thank you. Bye.
Goodbye.